Hello, everyone. This is Dr. Susan Hudson with another episode of Fertility Docs Uncensored. And I am here with my amazing co-host, Dr. Carrie Bedient from Fertility Center of Las Vegas. How you doing?
Lovely. How are you?
Good. And Dr. Abby Eblen from Nashville Fertility Center.
Hey.
Hey, girls. Y'all having a good afternoon today?
Yes, absolutely.
Good
Yes.
deal.
The
Restful
world has
afternoon.
slowed down and it is amazeballs.
I know. It's nice to slow down after the holiday season and kind of regroup and get your head back on straight.
Mm-hmm. So I feel like the magical questions this time of year, there are two. One is, what is the best gift you have received over the course of the year? And the other one is, what is the worst gift you have received? And so
over the course of the year or ever?
For the purpose of this question, ever, because
Okay.
I'm sure that will elicit better responses. But what is the most dramatically terrible gift you have ever gotten? And this can be from anyone for any occasion and be terrible for any of a dozen reasons of why it's terrible.
So I'll take this one. So I do consider like your birthday cake as part of a gift. Okay. And early in my career, I had already been diagnosed with celiac, so I can't eat gluten. And I went to work on my birthday and everybody got me a gluten birthday cake for them all to eat.
Wait, not gluten-free.
Oh, no. They totally knew I could not eat it. And they bought me a regular birthday cake.
Oh,
that was my worst present ever, in my opinion. Like, it's one thing if it's an accident, like, you know, if somebody just like brings me food, like I am more than happy to like pass it on. But like when you know I have celiac and you bring me a gluten birthday cake, I'm like, really?
Aww.
That was moderately self-serving.
Yeah, more than moderately. More than moderately.
What do you got, Abby?
Well, this isn't really the worst gift ever, but it was in the context. I dated this guy for a while, and we were the relationship was starting to run its course after a couple of years. And I knew things were not going well when he got me a blender for my birthday. I'm like, okay. But in his defense, it was like he gave me some margarita mix or something. But still, you know, when you're in your 20s and you're dating somebody, a blender's not really what you want for your birthday, you know.
That is not a romantic gift unless, unless you're maybe a hardcore alcoholic and love margaritas.
Maybe if you love margaritas, maybe that's a great gift, but
yeah. We so I think mine was my then boyfriend, now husband. So you can tell it's not a terrible gift because he's made
he survived it.
He made it.
He survived it. But I think he got he didn't get me nothing for my birthday, but he got me something really, really minor and small that was very out of character. And because we had been dating at least for 3-4 years at that point. And so every prior birthday had been very thoughtful, not necessarily huge. Like he got me, you know, a poster from one of my favorite artists when we were first dating. And like, it was a maybe $20 poster, but it was perfect. So I forget what it was that he got. It was something really minor, like, I don't know, a deck of cards or something like carnations or something like that. I'm like, really? You would have been better served to say you forgot and you'll make up for it later. But
you weren't like expecting a ring or anything at that point, were you?
Oh, no. But it was one of those things where he has never done that since. He has never done that since. And I did not have to pitch a high holy fit. It was just really, dude?
Yeah.
Are you trying to tell me something? Are you breaking up with me on my birthday? No, I'm not that crazy chick, but if I thought about it, I might have gone that route. Anyway, yeah, it was more lame rather than bad.
Yeah, he's just tired and didn't really spend a lot of time to pick your gift out.
Yeah, but I still love him.
Well, that's good. That's good. We're glad to hear that. Well, today we're going to do an episode all about questions about ovarian reserve and usually diminished ovarian reserve. So we're going to kind of start off here with this one. Hi, I'm 32 years old and struggling with secondary infertility, conceived first child, first month of trying. My OB-GYN tested my AMH when I expressed concerns about having trouble conceiving. And her AMH came back as 0.56. I started vitamins, prenatal, CoQ10, and vitamin D, and recently retested her AMH, which is now 0.88. Is this an increase that should be expected, or should I be concerned one of the tests is a fluke? We are getting ready for IUI, and my RE isn't doing a day 3 scan or testing FSH. Isn't this something I need to know where my ovarian reserve stands, or is it normal just to go straight to IUI without diagnostics?
I mean, I would say with that AMH, it's kind of like I tell patients, if we check your blood pressure today, tomorrow, and the next day, it's not going to be exactly the same thing. It's going to fluctuate up and down a baseline. And that's what I would kind of say with this. I think whether it's 0.56 or 0.88, I mean, it is abnormal, but it's not horrible. And you're 32. And for me, for my patients, it wouldn't really change what I'd recommend at that point. So I don't think there's a reason to keep checking it over and over again, because it's not going to be exactly the same. And whether it fluctuates up a little bit or down a little bit, it's probably not going to make a difference in terms of management.
I think I would definitely get the rest of the diagnostics, just because two things can coexist at the same time. You can have low ovarian reserve and you can have tubal dysfunction, or his sperm count can be low, or what have you. And so I would never blow it off, because I think all of us probably have at least one patient early in our careers where we made an assumption of, I know exactly what's going on because I have this one test that's abnormal. And then 6 months into treatment, you run another test and you're like, well, son of a bitch, I missed this from the beginning.
Yeah.
And so I would get the diagnostics anyway, because you want to make a plan with a full set of information.
Right. Especially, with diminished ovarian reserve, you need to think about what your long-term plan is. And so IUI, if you're wanting to have this one child and, this is baby number 2, maybe you're going to be done after that. It's not unreasonable to do diagnostics while you're doing the IUI cycle. There's no reason you can't do that. But if, say, we're trying for baby number 2 and we're wanting baby number 3 or number 4, maybe IUI is not the best solution. Maybe you need to be doing IVF to cryopreserve some embryos and then either transfer an embryo or do an IUI cycle after you have enough embryos for you to hopefully, fulfill your family goals later on. So I do think getting the full workup, there are some people out there who are not, just like there's some people who don't test AMH, there's some people who don't test FSH and estradiol. I think the 3 of us pretty much do both of those, and we like to do an antral follicle count. Ovarian reserve testing is not perfect. And so the more things that kind of support a diagnosis, I think the better. And then we can get a better idea of the full picture.
I would say that because you're 32, don't phone it in, because you're the type of patient where even if you do have just a couple of follicles, you're the one where we see more potential for success. Like your REI is going to counsel you very carefully, like, look, this may not work. But they will also probably counsel you, look, this very well may work. And so there's a little bit more gambling involved. And, I always tell my patients in Vegas, look, I've never spent a dime on a slot machine or any kind of gambling in Vegas, because I don't need to, because I gamble every day in my job. But this is where that gambling really comes in. And yes, it's a big step, but when it pays off really big. And you're the type of person at 32 years old who's had a baby before, where there's a really decent chance you'll get where you want to be.
Absolutely.
Good stuff. Good stuff. All right. Our next question. Hello, I am a 32-year-old physician who was recently diagnosed with premature ovarian insufficiency after not having a cycle for 3 months following discontinuing OCPs. Karyotype and labs are normal. FSH is 56, AMH 0.03. I have plans to start an IVF cycle despite knowing the low likelihood of success. We are planning to do a delayed start protocol with ganirelix, Clomid, then omnitrope and follistim. Is this the cycle you would recommend, or have seen be the highest chance of success? I know I will likely need to pursue egg donation. However, I want to give myself a chance and then move on. Thank you so much.
So that protocol it sounded like omnitrope and FSH, but preceded by
Clomid and ganirelix or something.
Yeah, ganirelix, Clomid, then omnitrope and follistim.
timing doesn't, granted,
It's a little,
it's not clearly laid out in the question, but that timing doesn't totally make sense to me.
yeah. I mean, just so our listeners know, ganirelix is an antagonist, and we sometimes use ganirelix in estrogen priming. So it's possible that that's starting off there, and then it stopped kind of in the first part of the cycle, and then later on it's restarted to keep you from ovulating. The Follistim, yes. The Clomid, I can say I've started using some oral medications with my injectables in really, really poor prognosis patients, because I've seen some people have more positive responses and fewer cancellations.
I would argue, though, that we're getting lost a little bit in the semantics. I think the big picture is her FSH is 56 and her AMH is 0.03. I think it's hard to say that this protocol is better than that protocol when your AMH is low. And, and I know she's an MD too. And, again, not to be negative, but I think there's not a lot. I mean, there's not one protocol that we do that we say, this is the one. Sometimes we try one. If it doesn't work, we have to cancel the cycle. We'll modify things and do things differently. But, I don't blame you for wanting to try. If I were in your shoes, I'd want to do the same thing. But I mean, being really honest, probably it's going to be real hard for any protocol to work real well, given the fact that you just have a really low egg count and a high FSH.
I mean, I would say probably the most important point of any protocol that you go through is that you have some suppression going into it, because you want to lower your FSH before you start stimming. Because I think if you do that, frankly, even if you don't take any medications with an FSH of 56, it's going to shoot high enough up on its own. And you just need it suppressed so that when it goes up, you know when it goes up and you know when to start monitoring. And so that's probably what I would consider one of the most important points of this type of protocol, because your FSH, no matter Clomid, gonadotropins, Follistim, whatever, your FSH is probably going to take care of itself without the medications. It's, can you suppress it beforehand and then remove the suppression so it rebounds and does its own thing.
Well, and to that end, too, one of the protocols that we used to do probably more frequently 5 or 6 years ago was a microdose Lupron flare protocol. And we would put patients on birth control pills for a month or so to do exactly what you're talking about, Carrie, to suppress the FSH. And then you're on a microdose dose of Lupron. It's a real small dose. And since you're a physician, you probably know that, what happens is when you first start Lupron, what happens initially is you have a flare of FSH. And so not only are you flaring on your own because you're coming off birth control pills, but you're also flaring because you're doing that microdose Lupron flare dose as well. And so that's another alternative. Again, I don't quite understand exactly what you're doing with the medicines, but if this doesn't work, that's another alternative. A lot of times I'll use that as a second choice for some of my patients if the first try doesn't work very well.
I do love me a Lupron flare.
It can work. It can work.
I think the kind of summary here is that in the situation of premature ovarian insufficiency, there's not a magic recipe. There
for one part, definitely,
there's an art to assisted reproductive technologies, and so give it a try, and if it works, great, and if it doesn't, know that there's other protocols out there, and ask your physician what other things can be tweaked in future protocols if you need to go that way.
Well, the one big positive I would say is that you're 32 and age makes a huge difference. Even if your AMH is 0.03, it's not that we want 32-year-olds to have an AMH that's 0.03, but if you're 32, you're going to do better than somebody who's 38 or 39 or 40 for sure.
Mm-hmm. Yeah. All right, let's go on to our next one. Hi, I've been seeing my fertility specialist since February, and my AMH has gone from 0.18 to 0.085 from February to May. As my doctor said that at my age of 34, I'll be 35 in October, that outcomes for IUI and IVF are the same around this age. Is this true? Should I just go to IVF? I'm on my second cycle of IUI currently, and I don't really want to waste time as my AMH is dwindling. Any advice would be most helpful.
Just to clarify, she said that she was told that IUI and IVF have the same success rate with a low AMH when she's 34 years old. Did I hear that right?
No, I think what she's saying is that nothing magical happens on her 35th birthday.
Oh,
I
okay.
think.
That
So
makes
number
more
one,
sense.
IUI and IVF do not have the same success rates.
Yes, they're wildly different, particularly when you are 34/35
Well,
years old.
if
Okay.
you find a normal egg, a normal embryo, that is.
Yeah, that
That's the
Right.
key. You got to get to that stage though.
that makes a lot more sense. I was trying to figure out how in anyone in their 30s, IVF and IUI had the same success rate, and it
Right.
makes much
I
more
think what they're
sense that
trying
it's
to
not
say
age.
is that when you sing happy birthday on your 35th birthday, nothing
There's
magical
not a switch.
happens. You know,
Yeah.
it
Yeah.
doesn't switch on or off. That, you know, time is very, very important. You should probably be as aggressive as you are comfortable being under this
Mhm.
situation.
Right.
I'm kind of seeing a trend when people are, you know, having these multiple AMH levels. AMH is going to vary mildly, like Abby mentioned earlier, that the difference between 0. 0.1 and 0.08, that's really not a difference in our
Yeah.
book. You know, it's a similar number. If it was, you know, 0.8 and 12, that's hugely different and very
Mhm. Yeah.
implications of much different things. So I think, Carrie, do you have any other advice for this listener?
I mean, I think one more IUI cycle is not going to make or break anything. If you skip it, if you do it, it's not going to make or break anything. The things that tend to be of bigger impact are going to be you getting frustrated regardless of what you do and taking 6 months to a year or longer off. And so I think what I typically tell my patients is, look, if your insurance covers absolutely everything for IUI and you don't have to pay for anything, great, do another one. If your insurance covers absolutely nothing and you have to pay everything out of pocket, jump to IVF a little bit faster. Given a one-shot vote, I think just about every fertility doc, if they're offered, you can do one more thing, it's going to be IUI or IVF. Every single one of us is going to say, okay, IVF it is. But a lot of it's going to depend on what your bigger picture is. We don't want you to get frustrated. We also don't want you to feel like I threw in the towel too early and went straight to IVF, because IVF is really good, but it's not foolproof. There's a real possibility that it won't work. And so we want you to be able to feel comfortable with your decision regardless of the outcome. And so I have people who go either way saying, screw it, I'm done with IUIs, take me to IVF. And the other people who are like, let me just do the 3. That's the number I had in my mind when I came in. I will feel better. And then we'll go to IVF if it doesn't work. And that's fine too. You know, one more in either direction is not going to make or break anything. Do what allows you to sleep well at night, and just do it with the intent of continuing forward with treatment, because the specific path, you know, do you go right or do you go left, doesn't matter as long as you still keep going.
Very good advice. Very good advice. All right, here's our next one. Hello, I love your podcast. It was a lifesaver for me when I started my journey. Background, AMH at 0.3, day 3 FSH 15. Some male factor with low morphology. We otherwise are really healthy with normal weights. Failed 1 IVF cycle, had 3 eggs, 2 mature, none made it to day 5. My husband and I took a few months off and conceived on their own. Right
Oh
now.
wow. See, there's a good example. It can happen.
Exactly. Right now, I'm almost at the 12-week mark, first baby, first
Oh,
pregnancy. So far, everything is looking good. Fingers crossed. My question is, what's the reality that we could conceive naturally again? Should we start trying as soon as possible? If we don't conceive after a few months of trying, should we go for another IVF round?
Do we have an age?
that's what I was just going to say. How old is she?
I don't have an age. I don't have
Age
an
makes a
age.
huge difference. I have a 20, she was 22 initially, that got pregnant unexpectedly with a really low AMH. And then she came to see me for egg freezing. And then she had another baby and still has a really low AMH, but she's really young. So I think that makes a big difference.
Mm-hmm.
There's one of the stories that has stuck with me ever since I was a first year fellow was that there was a physician who was really paranoid about her fertility. She had testing done. She had lost an ovary at an early age, and she had testing done, and her testing was abysmal. Her AMH was low. Her follicle count was like 3, and she was freaking out that she was going to need IVF. Well, you know, shortly thereafter, she gets married and she has 3 children without any problems, completely
Yeah.
spontaneously. And so there's a degree to which this testing is not entirely helpful, and age really does make a huge play a huge part in that. So love note to listeners, if you're asking questions, please give us your age, because it's really helpful giving advice. I would say if it's important to you, start early, but don't miss out on the joy that you have of a newborn. And if you want to breastfeed, breastfeed. And if you feel like you're losing your mind and your hair and your sanity while you are in the newborn phase, let it ride. Don't start fertility treatment immediately, because it's okay to do one phase of life at a time, and it will work out one way or the other. Whatever is supposed to be will happen.
Yeah.
But on another note, if you're in your late 30s or early 40s, I would probably start back pretty quickly, because in that situation, it's not as likely that you're going to conceive on your own, particularly with an AMH of 15 right now. It's kind of creeping up there. So, but I agree with Carrie. You don't want to rush the joy of having a baby and breastfeeding and all the fun that comes with that to rush back and try and get pregnant again.
Yeah. I think
Also,
a lot of this is a heart decision.
Mm-hmm.
And because as much as we say don't rush, as a perpetual rusher, that sometimes doesn't, work very well. And so, do what your heart tells you. If you want to be as aggressive as you can be as aggressive as you can be. If you are just kind of like, we're going to take this baby and work on the next one, it is reasonable to try. If you're going to try on your own, I would probably try for 3 or 4 months. I probably wouldn't try for a year. If you're going to go down the path of getting additional help.
Yeah.
Good advice.
All right. Let's do a couple more. Okay. Let's do this one. Love your podcast. Is there such a thing as weak or insufficient ovulation? Like, there is a range on how strong ovulation is, or is it that the egg quality is poor or follicle doesn't develop? As background, she's 35, DOR with male factor, AMH 0.8, FSH 10, AFC 7, sperm 1% morphology. Saline tubal perfusion okay, except left side spasmed, endometrial biopsy negative, hysteroscopy normal, tried to conceive for a year, never pregnant, regular 24 to 26 day cycles. Prepping for IVF, but doing medicated cycles with timed intercourse and IUI this next cycle while they're waiting for insurance coverage. Did 5 days of Clomid, and ultrasound showed that ovulation was near, but progesterone was under 2 on day 7 post-ovulation. So he said, I didn't ovulate well enough and need an HCG trigger shot.
So I'm going to make a plug for future episodes in that in the first half of January and I think the first half of February, we talk with Dr. Amy Beckley, and she is a pharmacist who developed a tracking device mechanism, drug, not a drug, but a tracking
device. It's a kit that you can buy called Prove. She has a web or an app. PROOV.
And so definitely tune into those episodes, because she talks about where she came from, and it's very much what your question is asking.
Yeah.
And, yes, if you have really low progesterone levels, that's not super convincing, and you probably are someone who's going to benefit by ovulation induction meds and an HCG trigger and some closer monitoring and those types of things.
So I think this is one of those, kind of chicken or the egg type of questions. I'm of the philosophy that your diminished ovarian reserve probably is contributing to your ovulatory disorder. And, and we all see this, we have people who come in with irregular periods, and they're, other docs have said, oh, you've got PCOS. And then we do a scan and we're like, crap, where's your ovaries?
Yeah.
and so we see that, diminished ovarian reserve can lead to an ovulatory disorder. So needing HCG to make everything happen the way it needs to happen is a reasonable, tool in our bag to use.
Yeah.
So the answer to your question, is there such a thing as weak or insufficient ovulation? The answer is absolutely yes. And there's different ways you can treat it with HCG or progesterone or whatever.
Mm-hmm. Good deal. All right. One more. Hi, grateful for your podcast. I'm 38 years old who recently had all the lab work and testing done. AMH 0.01, FSH 4.4, and 4 follicles. Healthy, no other pathology to note. HSG clear, never conceived. Partner sperm is good. Wondering if trying a cycle of Clomid IUI makes sense before IVF. My doctor says it's okay to do 1 or 2 Clomid cycles, then go to IVF because my AMH is already low. Once I undergo IVF cycles, what can I do to maximize each cycle?
Yeah, I mean, I think the bottom line is I agree with that. I mean, your AMH is not going to change dramatically in the next few months. And, you know, a few months of trying Clomid IUIs, I mean, if you get pregnant that way, like one of our listeners did, I mean, you win the ball game without having to go through IVF. So I don't think 3 months in the whole scheme of things is a big deal. And I think it would be fine to do that for a few months before you proceed to IVF.
Mm-hmm. I would agree with that. There are some things that are a little bit trickier to do with IUI and decreased ovarian reserve. You're a little bit more likely to have a follicle developing before we have given it permission to develop. And so there's a mismatch between the size of the follicle and its readiness to ovulate and the preparation of the endometrium. So oftentimes we see someone who's ready to ovulate really early and their endometrium is like, WTF, I have not gotten dressed for this party yet.
Yeah.
And so that can be a little trickier with IUIs, but I would agree with Abby. You have nothing to lose by trying. It's a month or two. Do it because if you win, it's the lottery and it's a good lottery. It's not like a $5 lottery. And give it a shot, because if it doesn't work, you're always going to go to IVF and you're already planning, which means you're not going to be spending a lot of time screwing around. And that's really the big thing.
That's right.
I think very, very true. You know, if you can do it the easy way, that's great. But if not, then there's other options, and
You're willing to go that way.
Follow your heart. All right, you guys. Well, I think we covered a lot of good stuff today. And to our audience, thanks for listening, and be sure to tune in next week for more. Also, be sure to subscribe and leave us a review on Apple Podcasts. Would love to hear from you. We're also on Instagram, Facebook, and YouTube, so make sure to follow and subscribe to stay updated on all things infertility.
You can also visit us on fertilitydocs.uncensored.com to submit specific questions. All questions will be answered on the podcast for the Ask the Doc section. We love episode ideas, so let us know what you want to hear.
And as always, this podcast is intended for entertainment. It's not a substitute for medical advice from your own physician. All right, we'll talk to you soon.
Bye.
Bye.
Bye.